Hello everyone, welcome to the test and evaluation program, and in this paper 3 we will be talking about explanation and questions related to neonatology. Neonatology is one of the high yielding areas of NEET SS, and many of you who are targeting INISS also, it's a proper specialty. Already AIMS protocol updates, Nelson updates, there are detailed videos which are there on the Prep Ladder Super Specialty app. I will be incorporating some recent actual super specialty MCQs or questions similar to the previous year questions of super specialty, so you get an idea of how questions are being asked. Additionally, certain topics which are not discussed in details but occasional question can be asked, I will try to take them a brief summary of those topics also. So let us start with the discussion. As is the norm, if you're targeting NEET SS, what are the areas you should focus based upon previous year trends? So the topics requiring focus in neonatology includes, first of all, we have neonatal resuscitation, NRP 8th edition. There is always one question from neonatal jaundice, always one question from neonatal resuscitation, and always one question from RDS. This pattern has been going on since many years, and directly or indirectly, something out of these three topics are always asked. So if I am preparing for NEET SS and my exam is day after tomorrow, I need to see neonatology, I will definitely have a look at. I'll spend full 1 to 2 hours looking at neonatal resuscitation, NRP 8th edition. Second, dose and therapeutic levels of neonatal medications. The favorite of examiners is caffeine citrate. I will do a brief review today. Apart from that, other neonatal medications and their protocols and their regimes you should go through. And even the drugs for the prevention of RDS like dexamethasone, betamethasone, where are you using hydrocortisone, those conditions, those topics you are supposed to read. Additionally, finally, congenital infection therapy, the therapeutics used there also are important from neonatology point of view. Then we have neonatal jaundice, as I said, NEC and neonatal sepsis, RDS, TTN, basics on CPAP, basics of NIV, ventilation, SpO2 targets, and BPD. BPD is again to be read from AIMS protocol. Every single line of AIMS protocol is important. Regarding ventilation, the ventilation graphs are generally not asked in NEET SS, they are asked in INISS. Having said that, if a graph on ventilation does get asked in NEET SS, you cannot, fight with the examiner. But generally speaking, the graphs are asked more often in INISS. When it comes to ventilation questions or CPAP questions, examiner will never ask you technical question. Examiner will ask you a case scenario. They will give you a case scenario, they will mention the settings, and they will ask what next needs to be done. So something practical, if you have been a good student, if you have worked in NICU, and you know the basics of CPAP and ventilation, these are easily doable questions. But for somebody who has not worked well and exposure is limited, you may find a bit of difficulty in solving such questions. I will try to take up one scenario in the discussion today. Then CDH and TEF are important. 3 scoring systems are important. One out of these 3 generally asked in the exam: APGAR score, Silverman-Anderson score, and Downey score. Like in the previous NEET SS, there was a question on APGAR score. In the preceding one, there was a question on Downey score, and 2 exams back, there was a question on Silverman-Anderson score. Then HIE is important. Fetal assessment from Cloherty is important. Cloherty, of course, it's a good book. We are supposed to read. You have read it before. But last week before the exam, fetal assessment from Cloherty, very important. It is better than any other pediatric textbooks. Direct questions are sometimes picked. Then hearing assessment in neonates, one of the favorite of examiners for unknown reason, whether NEET SS or INISS, you are supposed to go through. Congenital infections, all infections are important, but CMV, rubella, syphilis, HSV, toxoplasma, and HIV are important. In HIV, stick to the NACO guidelines and not the guidelines given in Cloherty. Maternal medications and effects on fetus, it not only includes teratogens, but also includes conditions like adaptation syndrome, withdrawal syndrome, etc. So these are the topics which will cover more or less 80 to 90% of all the expected topics in neonatology. Odd topic getting asked from an odd area or subsystem, difficult to predict. End of the day, you can't read everything. But if you have done a fairly good reading, this will cover majority of the topics. Let us start with question number 1. So question number 1, again, as I said, neonatal resuscitation. So I will try to cover 2 or 3 questions related to this. One of this question, it's a clinical question. It's not a previous year question, but it's a prototype question of how questions are sometimes asked. They will give you a case scenario. A neonate was delivered at 37 weeks via normal vaginal delivery with preeclampsia. Baby did not cry or breathe at birth. He was kept under radiant warmer, dried, airway was suctioned and positioned, and stimulation was performed. Evaluation revealed a heart rate of 30 per minute. What is the immediate next step in management? Now you need to analyze the question. Whenever they are giving a case scenario, analyze it. What is the examiner saying? The examiner is saying there was a baby who was born, birth happened. After that, initial steps were performed. All the initial steps were done. Now assessment was done and heart rate is less than 30 per minute. According to NRP guideline, any apnea or heart rate less than 100, even if it is less than 30, what are you supposed to do? Start with positive pressure ventilation. And if it is a term neonate or 35 week and above neonate, you do bag and mask ventilation, PPV on room air. So answer to question number 1 is A, use PPV on room air. It is a common misconception and common, tendency of us that sometimes we remember that heart rate less than 60, you should do chest compression and intubation. Never jump the steps. Unless bag and mask is contraindicated, you will first do PPV via bag and mask, and then only you will go to intubation and chest compression. Only when PPV is contraindicated, for example, diaphragmatic hernia, in such patients, you will directly go for intubation. Also remember that chest compressions, it's not a masala that you put everything in one dish together. There is always a way to go. And here, first you do PPV if heart rate is less than 100. Even if it is heart rate less than 100, less than 80, less than 50, less than 60 absent, first thing, PPV. And if the patient doesn't improve, then you go in for. The only exception where you will do chest compression together, again, will be a complete asystole in the child. But this type of scenario will be unlikely given to you in the exam. So always PPV takes precedence over giving chest compression if there is bradycardia in a newborn. Remember this rule. So answer to this question is use PPV on room air. Have a look at what NRP also says. In this question, birth was done, then the initial assessment was done, and initial steps were taken where they started with warmth, providing normal temperature, positioning airway, clearing secretion, drying, stimulation. Then the assessment was done. Apnea or heart rate less than 100. What are we supposed to do? PPV should be started in the child. And also remember the rule, if the baby is born less than 35 weeks, then you start oxygen 21 to 30%. However, if the baby is born equal to or more than 35 weeks, then room air is used for initial PPV. These are the rules for initial PPV. Right? So the answer to this is A. Moving to another case scenario of INISS 23, the exact question is not available, but based upon recall, student said an INISS, if you have given INI CET once upon a time, you know that INI people, AIIMS people are very fond of repeating the topics and repeating questions directly or indirectly. So this is one case scenario which was asked. Neonate undergoing resuscitation, not improving, having persistent apnea despite PPV, chest compression and epinephrine, they all have been done. History of abruptio placenta in the mother. Now, key points to see is persistent apnea, not responding to the usual therapy, resuscitation steps, and there is abruptio placenta in the mother. What can be tried? If there is abruptio placenta along with non-responsiveness, you should look for hypovolemia. Look for hypovolemia due to acute blood loss. And if it is suspected, you will put an umbilical venous catheter, or through intraosseous route, you will try to give 10 ml per kg of O negative blood and try to arrange the cross-matched blood as early as possible. 10 ml per kg. Nelson says that 10 ml per kg aliquots can be given. Aliquots means if needed, you can give more blood later on as well. 10 ml per kg, it is not given as bolus. Generally, it is given over 15 to 30 minutes is what we do. Right, 10 ml per kg. If it is not available, then you will have to use 10 ml per kg of crystalloid like normal saline. Normal saline is generally preferred over Ringer lactate in a neonate undergoing resuscitation. But this particular thing was the ask, because one of the options in the question, it was not a technical option. One of the option was consider O negative blood transfusion at the rate of 10 ml per kg. Something similar to this was one of the option, And if this was the question asked, my best answer would be marking that option. So similar question can be asked to you in the exam. Just add it to your revision notes. Question number 2. This question is similar to actual question asked in NEET SS 2023. So almost similar. The question is, which among the following is the dose of epinephrine if given via umbilical venous route during neonatal resuscitation? Now, let us come back to this question. Let us do a brief review of epinephrine, also called as adrenaline in NRP. When would you consider giving epinephrine? You don't start epinephrine in the initial part of therapy. It is given if heart rate is less than 60 per minute or there is asystole despite positive pressure ventilation and chest compression done for equal to or more than 60 seconds. This is the indication where you will be giving epinephrine, and by itself it is also a important potential one-liner. What is the preferred route for giving epinephrine? You will be giving through the umbilical venous route, which is the best. You will put a catheter into the umbilical vein. If not possible, you can go via intraosseous route. Which bone will be preferred? Tibia will be preferred. If not possible, you will go via endotracheal route. Peripheral venous route is not the favored route of giving epinephrine during resuscitation. And what is the dose? Dose depends upon the route that you are using. Venous osseous route, the dose is always 0.2 ml per kg of a dilute solution, 1:10,000 solution. The normal epinephrine vial which comes, that is 1:1000. We take 1 ml of that and add 9 ml of normal saline to make the stock solution. The total strength of that solution is 1:10,000. That strength should be made before the resuscitation is done, and generally it is created by the nursing staff. But being residents and being tomorrow consultants, it is our duty to check whether the appropriate solution strength is being used or not, right? So what is the solution strength? 1:10,000 of this solution. Of this stock solution, you will be using a dose of 0.2 ml per kg. Now, there is no time for calculating the actual weight. So, you can go by the estimated fetal weight, or, just immediately after the child is born, every second counts. So, you don't have the time. General idea you can have about the child. But it is always better that you look at the estimated fetal weight and have an idea of how much weight the child is going to be having when he is born. So, 0.2 ml per kg of 1:10,000 solution. It is the same as 0.02 mg per kg. Be careful what is being asked. If they say ml per kg, the answer will be 0.2. If they say mg per kg, the answer will be 0.02. Also have a look at the strength of the solution that is being used. If it is tracheal route, the dose is different. The dose will be 1 ml per kg, which is the same as 0.1 mg per kg. So there is a difference of 1 decimal between ml per kg and mg per kg. Also, in the older NRP guidelines, they used to give a range 0.1 to 0.3 for venous route, but now they use a single value 0.2 ml per kg, right? Because tracheal route is not a very efficient route, so the amount that you are giving needs to be on the higher side. That is the rationale. Whatever I have written on this slide, very important, you can get a fresh MCQ or a similar MCQ out of this close to the exam. The basics of resuscitation you already know. All of you have done a lot of resuscitation, and probably you are doing more resuscitations than me. So practically you will be doing better. But this particular thing will be asked in some way or the other, and it was asked in 2023 exam as well. Now have a look at the question. Question is saying, which among the following is dose if given via umbilical venous route during neonatal resuscitation? So it should be 1:10,000 dilution and 0.2 ml per kg. So B is your correct answer. If you see carefully, other options are not correct. Moving further. Question number 3. A neonate was delivered by cesarean section to a mother with gestational diabetes. SpO2 was noted to be 80% at 5 minutes of life. What next needs to be done? This is not resuscitation. You don't need to do resuscitation. The examiner only wants you to know that small box which is on the side of neonatal resuscitation protocol, which we all tend to ignore, right? I'm quite sure whenever you read resuscitation, you tend to ignore that small box of preductal SpO2, which is target preductal SpO2, which is given on the side. Many of you do that. So this question will make sure that you don't forget. What is the table? Have a look at this table. This table, you will find it there. So target predicted SpO2, 1 minute, 60 to 65, 2 minutes, 65 to 70, 3 minutes, 70 to 75, 4 minutes, 75 to 80, 5 minutes, 80 to 85, 10 minutes, 85 to 95. Okay. Now, 5 minute, 80%. Target is 80 to 85%. Target attained. Do you need to do anything? No. If the target is attained, only observation is needed. Okay. If the target is not attained, then only you will try to start with oxygen, and don't directly jump to 100% oxygen. Always start with minimum. Room air already has 21%. So start with somewhere around 30 to 40% of oxygen. That is what we practically do. So question number 4 related to APGAR score. So a term newborn is delivered at 1 minute of life. He has good respiratory effort with a loud cry. He sneezes on reflex stimulation of the nostril. Heart rate is 110 per minute. Active movement with flexion of all limbs. Despite free flow oxygen administration, baby is showing central cyanosis. What is the total APGAR score? What are the components of APGAR score? These are the components. You can see the 5 components: A, P, G, A, R. 3 types of scores: 0, 1 and 2. Most of you already know. Let us calculate in this child. Look at these options. The examiner is saying good respiratory effort with a loud cry. So you get a score of 2. Sneezes on reflex stimulation of the nostril, score of 2. Heart rate is above 100, 2. Active movement with flexion of all limbs, 2. What about the appearance? Despite oxygen, central cyanosis is there. If there is completely blue, score of 0. 2 plus 2 plus 2 plus 2 plus 0, total score 8. Don't get alarmed. Few children can have occasional cyanosis. Acrocyanosis is more common, but sometimes peripheral as well as mild central cyanosis can be there. And this is just 1 minute of life. So we need to see what happens at 5 minutes of life as well. So this can happen in certain children, but this is generally a normal APGAR score. So answer to this question is C. Remember, 7 or above is normal score. 4 to 6 is moderately depressed. Some asphyxia may or may not be there. 0 to 3 is severely depressed APGAR score, indicates likely severe asphyxia. But asphyxia APGAR score is only a predictor. It is not a diagnostic. There are other predictors of asphyxia as well. Question number 5. This question has been asked in NEET SS 2021, NEET SS 2022. Can it be asked again? Why not? Can a similar question be asked? Why not? So we'll do a quick review. 27-week preterm is being given caffeine citrate for apnea. You all have used caffeine citrate as it's a drug of choice for apnea of prematurity. Which of the following shall be the optimum blood therapeutic level of caffeine citrate? If you look at the options seem to be taken from AIIMS protocol. The answer to this question is C. There is a minor variation between what AIIMS protocol says and what Cloherty says. So what is the blood therapeutic level of caffeine citrate? Remember the values. AIIMS protocol says it is 8 to 20 micrograms per ml and Cloherty says 5 to 20 microgram per ml. Examiner will not ask you to choose between them. Don't worry. Examiner who's making your exams, he or she, they know that these are minor differences. They are pediatricians. And some of them are having experience in pediatrics longer than you and me have come out of school or joined medical profession. So don't try to go into unnecessary controversies and don't waste your time. Examiner will always put options which are non-overlapping and non-controversial. So what about caffeine citrate? It's a hot topic. Every system I try to take a few points about a drug. Caffeine citrate has to be remembered inside out when you sit in the exam. So brief review, caffeine citrate is drug of choice for apnea of prematurity. It also decreases the risk of bronchopulmonary dysplasia. It belongs to which group? It belongs to a group known as methylxanthine groups. I hope you know that methylxanthine group also includes theophylline and aminophylline, but they are not used. Particularly theophylline has a narrow therapeutic index, so it is avoided these days. Caffeine citrate primary mechanism, it causes antagonism of adenosine. And adenosine is generally involved in suppression of the respiratory stimulation. By antagonism of adenosine, it causes increased, sensitivity of respiratory center to any changes in the oxygen and carbon dioxide level and reduces the chances of apnea. Dose is 20 mg per kg loading. Loading of caffeine citrate, the base is 10 mg per kg, base is always half, and followed by 5 to 10 mg per kg per day of caffeine citrate. The maintenance dose should be started 24 hours after the loading dose has been given. And the therapeutic level, as I said, it is 8 to 20 microgram per ml according to AIIMS protocol. Half-life is 101 hours mean. Don't look at the range, mean value is good enough. Continue till what age? This is important, and this is, if as far as I remember, it's an old INI SS question already. So I'm putting a Q as well. Continue till what age? 34 weeks of post-menstrual age, and provided no apneic episodes have occurred in the last 7 days. Finally, for how much time you will monitor? See, caffeine citrate has a long half-life. So you will monitor for 5 to 7 days for apnea after drug stoppage. What it means is, suppose today I'm recording, today is Saturday, right? Right now as I'm recording this video, today is Saturday. So today if I stop caffeine, see, child has been apnea free for more than 7 days now, and his PMA is also beyond 34 weeks. So it is time for me to stop caffeine. If I stop caffeine today, I cannot discharge the child tomorrow. You understand? Because caffeine has a long half-life, and it takes roughly about 5 to 7 days for actual, results to be seen, whether if you stop caffeine, apnea comes back or not. So if I'm stopping on Saturday, till next Friday, I would not be discharging the child. Maybe on Friday or next Saturday, I would be comfortable enough, provided there is no apneic episodes in the child. So you need to monitor for 5 to 7 days after stopping. And if you're planning a discharge already, then you should start, tapering or stopping stopping caffeine citrate much before the actual date of discharge comes in. The only rule is child should be apnea free for 7 days and post-menstrual age of 34 weeks should have been attained. Right. So details are already there in the detailed videos. You can always have a look there. Question number 6. Now this comes the tricky part. This was a tougher question. This may look easy to you. When you sit in the actual exam, the same question becomes tough. When you're watching a cricket match, it is very easy for us to say, Jasprit Bumrah, why is he, not bowling a yorker? When you are a bowler and you are actually playing, you will understand how difficult it is to bowl a yorker. And the same rule applies here as well. All the questions that you see on recalls or all the questions which I tell in a video discussion, they appear to be easy. They appear to be easy in a grand test because you're not actually sitting in the exam. When you actually sit in the exam, negative marking looming in, one question here or there, your dream seat, your dream super specialty seat can be in your hand or it may move out of your grasp. That creates uncertainty and mistakes happen. So it was a tough question. NEET SS 24. From as far as I know, almost similar. Minor variations in the information can always be there. So the question is, 28-week neonate developed respiratory distress soon after birth. Let us assume it is RDS, right? He was started on nasal CPAP with FiO2 30%. Fair enough. He's on CPAP of 6 centimeters of saline and FiO2 is of 45%. However, he's still in respiratory distress with persistent chest retractions. SpO2 is varying between 90 to 95%. What is the next step in management? See, he's on CPAP. Good. He's on SCPAP with FiO2. Okay. Target attained. Target is somewhere between 91 to 95. So 90 to 95, SpO2 is okay. But the distress is persisting. Means the distress has not settled. It means the child is not respiratory-wise totally stable. You need to do something. What exactly are you going to do? In such a child, you have multiple possibilities. Either you can, increase the current settings of CPAP and FiO2, or you can go for intubation, or you can wait and watch. Wait and watch should not be an option because work of breathing is more, distress is there. You will have to make the child comfortable. Okay, even if the target is attained. So observation cannot be the answer. Reduce FiO2, definitely not. Child target is attained and child is having some distress. So reducing FiO2 will not be the option. So C cannot be the answer, A cannot be the answer. Now we are stuck with B and D. Should you intubate and start mechanical ventilation? No. Till the CPAP value of about 7 to 8 centimeter of saline is attained, or you have touched that FiO2 cutoff of 50 to 60%, you will not intubate the patient. Well, I know it's tough. Let us come back to this question. First, see what Nelson says, what AIIMS protocol says, and what the guidelines say, and then we come back to the question again. Because similar question can be asked and it can be a rank decider. So Nelson 22nd edition says that when would you intubate? You would intubate a neonate with respiratory distress if there is either apnea, here there is no apnea, or there is respiratory failure. What are the definition for respiratory failure? Have a look here. So when do you give mechanical ventilation after intubation in RDS? Nelson says they require infants with respiratory failure or persistent apnea require mechanical ventilation. Now what are the definition for respiratory failure in preterm neonate? First, if the arterial blood pH is less than 7.20. Is it there? No. PaCO2 equal to or more than 60 millimeters of mercury. Is it there? No. SpO2 less than 90% despite oxygen concentration of 40% and nasal CPAP between 5 to 8 centimeter. Is the SpO2 less than 90% and have you attained the maximum CPAP value already? No. And fourth, persistent or severe apnea? The answer is no. So there are no indications of intubation and ventilation which are being fulfilled. AIMS protocol makes it more simple. Let us look at what AIMS protocol says. AIMS protocol says mechanical ventilation. When would you ventilate the child? Neonate with worsening respiratory distress scoring or hypoxemia or hypercarbia despite CPAP pressure of 7 to 8. Here the value is 6 centimeter. And FiO2 of 60% or more should be intubated and ventilated. Here the FiO2 is 45% only. So there is still scope. If an easy thing can work, if a non-invasive thing can work, why to intubate all the way? Don't struggle and don't go for higher things just for the sake of it. It's like simple thing. If I can pick up a thing in front of me and just eat it, why should I bother about, finding some device to pick it up and cooking something new? If already a good quality food is there in front of me, I will eat it. Always go for simple things. Always go for easy things. If ampicillin gentamicin is working in a child, why would you give linezolid or colistin in the patient? When ventilation is being done, if PPV alone is working, why would you go for chest compression? Similarly, in a RDS patient, if CPAP alone is working and there is margin for CPAP improvement, first you attain maximum, then you go for intubation and ventilation, right? Because always guidelines check whether you have exhausted a particular thing and the next step indications are being fulfilled or not. You might be thinking, why am I giving so much of ridiculous examples? Our brain is like that. Nonsense things, ridiculous things do stick around. And these are not ridiculous things. This is an area I have noticed. Scenario-based questions on RDS are being asked. Tough questions are being asked. So I just want that your question, one rank descending question, if it gets asked, should not go wrong in the exam. That is the whole point of me talking so much about this topic. So what do you need to know? Let us summarize it. So approach, if you get a similar question on INSS or NEET SS, how you're going to approach the question. Suppose examiner says there is a suspected preterm RDS patient. What is the first thing you will do? Oxygen you can try, but oxygen itself is not going to be much effective. You will start the patient on nasal CPAP. Nasal CPAP. Many people write PEEP also. So CPAP and PEEP are not the same. CPAP is continuous positive airway pressure. Throughout the respiratory cycle, you are giving a positive pressure. PEEP is positive end expiratory pressure. So only at the end expiration, where the chances of collapse are maximum, you are giving a pressure. They are not the same, but CPAP provides PEEP as well. Remember, I am repeating, CPAP provides PEEP also. What it means is that when they say PEEP is being provided or when they say CPAP is being given, so CPAP and PEEP for practical purpose, we can sometimes consider to be the similar thing. They are not the same, but we can consider to be a similar thing, right? So start nasal CPAP. Now, when you start, examiner can ask you what are the parameters you should be starting. Always start nasal CPAP on 5 centimeters of saline. 4 centimeter of CPAP is given only during tapering, only during weaning away, not during initial. Initially, you start with 5 centimeter saline. 5 liter per minute should be the flow of air, of oxygen. FiO2 should be 25 to 30%. Don't start 100% oxygen directly. And the target SpO2 during CPAP when you start should be 91 to 95%. These were parameters taken from AIMS protocol as well as Nelson. So start nasal CPAP. Now, when you start with CPAP, monitor the child. You can take the help of the Silverman, Anderson or Downey scores. Now you will have two possibilities. First possibility, the target is achieved. When I say target achieved, it means SpO2 is between 91 to 95% and there is no distress in the child. There is no respiratory distress clinically. In such patient, what you will do? You will continue CPAP. And then if the patient is stable, bring FiO2 to minimum. First you decrease FiO2 and then decrease CPAP to 4 centimeters of saline with FiO2 between 21 to 25%. And once the child remains stable on this as well, again, it will be a clinical decision based upon the monitoring that you are doing, then you will stop. You will stop CPAP. You will stop CPAP in the patient. So this is how. So first decrease FiO2, then decrease CPAP. And decrease CPAP to, if you are already at 6, decrease to 5, then 4. And after 4, then you stop it. Okay. If the target is not achieved, I'm assuming, I'm giving it in a way that practically these are the scenarios examiner can ask you. Now, if the target is not achieved, let us assume target is not achieved. Target is not achieved. Or the patient is having distress. Respiratory distress clinically is present. In such a patient, what you will do? In such a patient, you will increase FiO2 between 40 to 60% plus minus. You will increase the CPAP value as well. Examiner will not ask you to pick one of them, but practically if you have to take a call, you can, if a patient is at 30%, you can increase to 40%. And FiO2 40%, the next thing that we normally do is we increase the CPAP by one value. We increase from 5 to 6, then you make it about 7 or so, and FiO2 should be around 60%. Right? So these are the things that you have to do. You have to increase FiO2 or you have to increase CPAP. Which one to do? Again, there is no consensus. It's more of a practical thing. But a lot of centers, they prefer first increasing FiO2 followed by increasing CPAP. I again repeat, examiner will not ask you to choose between these two. Okay. But generally, FiO2 increase can happen immediately. CPAP, if you feel the patient work of breathing is more, then increasing a bit of CPAP is better. Then let me put it like this. If you feel there is no hard and fast rule for this, but generally, if SpO2 is the problem, you try to increase FiO2 first. Generally, if you feel that work of breathing is the problem, then you try to increase CPAP also, but generally both of them are done in tandem. Okay. Now, if you have already reached a FiO2 value of 60% and above and CPAP of 7 to 8 centimeter and above, and it is not working, it is failing. It is failing. This is the indication you will do SRT. What is SRT? Surfactant replacement therapy. InSure technique, gold standard technique, or you can go for LISA or MIST technique, and you will consider ventilation. You will consider ventilation. Now, people will say, sir, after surfactant, shouldn't we go back to CPAP? We generally go back to CPAP if failure of CPAP has not happened. If failure of CPAP has happened, then obviously you have to consider ventilation. So first give SRT, go back to CPAP and consider ventilating the patient if the patient is not improving. In ventilation, AIIMS protocol says, first go for NIPPV followed by intubation and mechanical ventilation. And always remember that high frequency nasal cannula HFNC has a high failure rate. It is not used yet. You may use it, but it is not recommended yet for use in RDS patients, particularly extreme prematurity or extremely low birth weight neonates with RDS. Looks a bit tricky? It's not. You just have to look at the general principles. Deliberately, I have not gone into the indications or, those tables and flowcharts. If I'm an examiner, this is based upon my view of how questions have been asked in the recent last few year exams. Examiner will give you a case scenario and they will say, what are the case scenarios they can ask you? They will give you a case scenario of RDS and ask you what is the first step. So your first step will be starting nasal CPAP. What values? These values you have to start. Then you have to see target achieved, no distress. You continue CPAP but try to taper it. First, what you decrease? You first decrease FiO2, then you decrease CPAP and then you stop it. Now, if the target is not achieved or clinical distress is present or you're doing Silverman-Anderson scoring system, Dowley scoring system, and the scoring systems show progressive deterioration. In such scenario, you will increase either FiO2 or CPAP. You will not intubate the patient directly. FiO2 40 to 60%. If it is already low, you increase FiO2. Or if you feel CPAP is 5, patient can benefit by increasing it to 6 or 7. You increase to 6 to 7. Beyond 7 or 8, we generally don't go beyond that. And if that is also not working, you have to intubate the patient. If already CPAP is at 5 or 6 and you feel more CPAP can be given, it has not totally failed, you will give surfactant and you will go back to CPAP. However, if already criteria for indication for ventilation have been fulfilled, the Nelson criteria I told you, then you have to start on ventilation. Now, AIIMS protocol says first you give NIPPV, non-invasive positive pressure ventilation, and then you intubate and put on mechanical ventilator. Individual minor variations occur in practice. They occur across protocols, and these variations occur even in what your HOD or what your head of unit likes. End of the day, what we do in a unit is guided by what our HOD or unit head likes. And let me tell you, many times they have their own, preferences, to put it softly. They have their own preferences. But when it comes to entrance exam, as far as I know, this flowchart which we have made is fairly safe for your exam. I've taken a lot of time. Don't worry, I'm not going to spend so much of time in the other explanations. This particular thing, it deserves. And I have discussed it in details in my regular videos and my rapid revision videos also. But just summarize and write it somewhere. And you want to annotate and add more things, most welcome to do that. So now have a look at the question. His CPAP is 6 centimeter, FiO2 45%. Target is attained, but respiratory distress with persistent chest retractions are present. So I would like to increase CPAP in the patients. B is answer. Okay, you know the answer now. Question number 7. Infant born to diabetic mother is found to have jitteriness, tremulousness, and hyperexcitability at 36 hours of life. All of the following can be a cause. If there is jitteriness, hyperexcitability, CNS involvement features in the first 2 or 3 days, the most common cause in a diabetic mother's baby is hypoglycemia. It can also occur due to hypocalcemia and sometimes due to hypomagnesemia as well. But the odd one out here is hypokalemia, and that is the answer. Remember, if you have such a clinical picture, the first possibility will always be hypoglycemia. Second possibility will also be hypocalcemia, and third possibility will be hypomagnesemia. Hypomagnesemia. Right? This is the sequence you are supposed to follow. Question number 8. A day 2 term neonate developed poor feeding, tremors, excessive crying, nasal stuffiness, and poor sleep. He is not sleeping. You know that newborns mostly sleep all the time. Sepsis markers negative. Mother has been on SSRI for mental illness. Likely diagnosis in the baby. This is a syndrome known as neonatal adaptation syndrome, also called as poor neonatal adaptation syndrome. D is your answer. Now, if the mother is on opioids or mother is on antidepressants and close to the delivery and she now delivers a baby, the baby can have problems. So what are the 2 types of problems which can happen? So effects of maternal medication, there are 2 types of syndromes. Generally, these are used interchangeably, although they are not the same. So first syndrome is neonatal abstinence syndrome. Second is neonatal adaptation syndrome. It is also called as PNA. What is the full form of PNA? PNA stands for poor neonatal adaptation. This is the other name. Look at the first one. Neonatal abstinence syndrome. The primary cause is withdrawal from physically addictive substances, mainly opioids, to which the fetus developed a dependence in utero. Understand like this. I am a pregnant lady. I am taking opioids. My baby in utero is also getting opioids. And not only I am an addict, my fetus is also an addict. Now fetus comes into this world. Now fetus body, there is withdrawal. Opioid withdrawal will happen because fetus also wants opioids because he has become addicted in utero. Right? I'm telling in a non-technical way. This syndrome is called as neonatal abstinence syndrome. Most commonly seen with opioids. It can also be seen with benzodiazepines. So mainly opioids like morphine, but can occur due to benzodiazepines as well. And even opioid-based cough syrups, their chronic use can also cause this problem. So symptoms, they will be severe and they will require medical intervention and medications. So duration of symptoms, what are the symptoms? The symptoms can be very similar to withdrawal symptoms, like tremors will be there, jitteriness will be there, excessive sneezing can be there. The child may have, autonomic instability. Nasal stuffiness will be there. Sleep problems will occur in the child. So all these problems will be there, and there will be history of maternal intake of opioids. And the child will require hospitalization, and you need to give medications. What are the 2 medications which are used according to Cloherty as well as Nelson? Morphine and methadone are the preferred ones. So you can use either morphine and methadone. And Cloherty further says that many patients do not respond to this as well. So you need to add clozapine also, and then taper it gradually in the patient. Sometimes, non-pharmacological measures can also be tried. On the other hand, neonatal adaptation syndrome occurs when there is exposure to psychiatric medications, especially SSRIs and SNRIs antidepressants in utero. And it is the neonatal adaptation syndrome, also called as poor neonatal adaptation syndrome, is a combination of drug toxicity as well as transient withdrawal effect. It is not just addiction. Withdrawal effect along with toxicity can produce. The symptoms are milder. They can persist for the onset can occur in the first week of life, but they can persist for, according to Cloherty, up to 4 weeks also. And they typically resolve within days, although they may last up to 4 weeks. And here, medication is only really needed. You need to give supportive therapy. You need to monitor in the ICU. And giving SNRIs or SSRIs to the child is generally not needed in such patients. So what are the symptoms of neonatal adaptation syndrome? Remember, abstinence syndrome, opioids, benzodiazepine, adaptation syndrome, SSRIs, SNRIs in the mother. Okay. Now, what are the clinical clues? The child in adaptation syndrome, SSRI and SNRI related, antidepressant related, the child will have high-pitched cry, hyper-irritability, seizures, sleep deprivation, sleep fragmentation. So sleep will not be proper. Normally, newborns just wake up for taking feed and then they sleep. This sleep will disappear in the child. Sneezing, excess sneezing in a newborn will happen. Newborns sneeze very cutely, but newborn sneezing a lot in a mother with antidepressant, it's not cute in the newborn. Tachypnea, hypertension, tachycardia, sweating, excessive sucking, poor excessive feeding, yawning. Let me highlight the keywords. Sleep problems, high-pitched cry, sneezing, yawning, sweating, tachypnea, and tremors. These are the features. If they are present, immediately it should come to your mind. It could be neonatal adaptation syndrome, right? Diarrhea, excessive weight loss and vomiting will occur if the symptom persists for long, but GAT symptoms are generally not always present in the child, right? So these are the syndromes, the features that suggest neonatal adaptation syndrome. Moving to question number 9. Neonate was born, detected to have limb abnormalities like pseudosyndactyly. Can you see this patient? Pseudosyndactyly. Amputation of the digits has happened. And hypoplasia of few fingers on the left hand is shown. What could be the likely cause? Whenever you have pseudosyndactyly amputation of the digits and it is asymmetric in nature, it could be an amniotic band which has, in utero caused constriction, compromised vascular supply and led to limb deformity. So answer to this question is amniotic band syndrome. C is your answer. Let's do a quick review because this topic is not per se there in Nelson and other standard resources. Amniotic band syndrome. Early rupture of amnion in utero can produce fibrous bands derived from the amniotic sac. These bind and entangle the fetal parts between amnion and chorion sometimes, and the child, gets compromise of vascular supply. Risk factors, there are 3 important risk factors, although it is not genetic. First, pregnancy, higher risk. Misoprostol use in pregnancy, higher risk. Preterm babies generally have higher risk. Limb defects are most commonly seen. It can also have CNS or spinal defects, and very rarely you can have GIT defects, particularly anterior abdominal wall defects also. And the limb defects include pseudosyndactyly, amputation, limb or finger swelling. Sometimes the entire, if there is a ring forming around the wrist, then the entire hand can also get involved. And usually it is focal and asymmetric. It is not symmetric in nature. In fact, presence of symmetry goes against amniotic band syndrome. If both the hands are hypoplastic, you should think of something else, maybe thalidomide or maybe some, congenital infection or some syndrome. But whenever you have asymmetric finding, one possibility will be amniotic band syndrome. And fetoscopic band lysis, it's a type of fetal surgery which is being tried in these patients. Finally, question number 10 related to HIE. A neonate delivered by cesarean section had delayed cry, required resuscitation with chest compression, umbilical artery blood pH 6.9 with low Apgar score and hypotonia. What is the diagnosis? HIE could be likely. He was started on oxygen, IV fluid, shifted to ICU and evaluated. Now, he is responsive to minimal stimuli. Just a minimal stimuli is causing responsiveness. Tone is normal, Morrow's reflex is intact, pupils are midriatic, very important clue, and weak suck reflex but otherwise normal, means no seizures. No seizures mentioned. Midriasis, intact Morrow, weak suck reflex. Responsiveness to minimal stimuli is called as hyper alert status. Remember, hyper alert status means minimal stimulus will cause hyper responsiveness in the child. Hyper alert means there will be minimal stimulation causing minimal stimulation will cause increased activity in the child. So, this is all fitting into HIE Sarnath at Sarnath stage 1. 3 stages are there, 1, 2, 3, mild, moderate, severe. It is all fitting into HIE Sarnath stage 1. Let's have a look at the Sarnath stage. This is the Sarnath and Sarnath staging. What are the clues in this question? There is a weak suck reflex which is there. Strong Morrow's reflex is there. Pupils were midriatic. seizures were absent, and hyperalert status was there, and otherwise the tone of the child was, muscle tone was normal, although mild hypotonia can go plus minus here as well. So tone alone will not be a feature because mild hypotonia can suggest stage 2, but stage 2 will generally have common seizures and meiosis, which are not likely in the patients. That is why stage 2 and stage 3 are not likely. Stage 1 is the likely diagnosis. And also remember, stage 1 are the patients who are having excess sympathetic activity. Stage 2 patients are the ones who are having parasympathetic activity. And stage 3, both the sympathetic and parasympathetic activities are depressed. Now, HIE is a topic on which one-liners are being asked in NEET SS and INISS. There was one INISS question. A recall could not happen, unfortunately. But students said that a couple of years back, in INISS specialty part, neonatology, there was a question on EEG features in term HIE and predictors of prognosis. There was something related to that statement-based tough question. Even the options could not be recalled. And when I did a search, I found it is there in most of the review articles, and in the new Nelson 22nd edition also, similar table is there. So the question probably was framed from some review article. Let us have a look at some additional points. Let us add these points to the notes. First of all, in HIE, increased glutamate activity and increased NMD and AMP activity contribute to neuronal injury. Second, MRI and MR spectroscopy are sensitive investigations for HIE. Third, high lactate by creatinine ratio, if you find on day 1, it has poor prognosis. On the other hand, if lactate is not elevated, better prognosis is seen according to Nelson. Gold standard for NICU monitoring is always multi-channel EEG with video. Minimum 24-hour monitoring is needed. If not available, then you go for amplitude integrated EEG. INISS previous year topic, the one I was just telling you, EEG in asphyxiated term infants. What do you need to know? This is the table from Nelson. It says, when you do EEG in asphyxiated term infants, that is HIE patient, good prognosis or favorable outcome is seen if there is mild depression on day 1 and normal background activities comes by day 7. But unfavorable outcome is seen if there is predominant interburst interval more than 20 seconds on any day, burst suppression pattern on any day. What is burst suppression pattern? Burst, then suppress. Burst, then suppression, then burst, then suppression. Isoelectric tracing on any days, flat line, and mild or greater depression after day 12. So these are the criteria. Don't try to go into unnecessary details of trying to read EEG unless you are focused on neurology part. But this particular table could be life-saving if a similar previous year question gets asked in INISS. So we are done with the additional points. And also, I hope you know that we have to give phenobarbital, we have to do therapeutic hypothermia, selective neuronal cooling, 33.5 degrees Celsius, minimum 6 hours, maximum 72 hours in such patients as a neuroprotective therapy. Moving to question number 11. This question is almost similar to the NEET super specialty MCQ asked in 2024. A neonate with suspected kernicterus was evaluated with OAE for hearing evaluation, and initial OAE at 48 hours of life was normal. For other neurological problem, the baby was admitted and managed. Now he is being discharged. What test should be done prior to discharge? Now, what we are looking at is a child with kernicterus. Kernicterus refers to chronic bilirubin-induced neurological damage. There is a tetrad of kernicterus. The tetrad of kernicterus includes 4 things. There is sensory neural hearing loss. There is upward gaze palsy. There is extrapyramidal, also called as choriothetoid or dyskinetic cerebral palsy. And fourth, there will be dental enamel hypoplasia. These 4 things which occur together are the tetrad. So, kernicterus patient needs to be evaluated for underlying hearing loss. And which hearing loss occurs? Sensory neural hearing loss. Now, when it comes to the testing for hearing in a newborn, if it is a low-risk infant and we are generally doing testing, it is always, OAE, autoacoustic emission is the test which is employed. It is easier to use, takes less time, technically less, challenging, and the result is interpreted in the form of, pass or refer. Refer means that you need to repeat the test or you need to, do additional testing as well. The problem with OAE is that it will miss many of the auditory nerve damage related sensory neural hearing losses. And that is why repeat OAE testing will not be recommended. In fact, in this patient, actually the first test should not have been OAE alone. It should have been AABR. What is AABR? Automated audiometric brainstem response. It is not the same as BERA, it is different. Let us first look at the 4 options which are given to you. Option number D cannot be the answer. Acoustic emitters testing is a testing which checks for conductive hearing loss, particularly related to middle ear pathology. Here there is no middle ear pathology which we are suspecting, and so D is not likely to be used. In fact, it is not useful as a screening test anyways, except if there is a established middle ear dysfunction. BERA again will not be a screening test. BERA is difficult to perform in a newborn and it is not a screening test. There are 2 screening tests which are available. OAE is also a screening test and AABR is also a screening test. One OAE has been done. Which second test will you do prior to discharge in a high-risk infant? The answer to this question will be B, that is perform AABR. Let us try to simplify what do the guidelines say, what does AIIMS protocol say, and what do the various other textbooks say. Regarding hearing assessment in a newborn, first thing is 136 principle. This principle is mentioned in the AIIMS protocol as well. This 136 principle says that in a newborn who requires hearing screening, screening should be done by 1 month of age. Audiological diagnosis should be made by 3 months of age if there is hearing loss, and enrollment for early intervention should be started by 6 months. So, screening done by 1 month, diagnosis by 3 months, and intervention or therapy started by 6 months. That should be the principle, 136 principle. Second thing is regarding the screening procedure. If you have a low risk baby, then you will be doing OAE alone within 24 to 48 hours of birth. Then if it is abnormal, if it is normal, you don't need to repeat it. If it is abnormal, you will repeat either OAE or AABR either prior to discharge or on the first follow-up visit. However, if the baby is high risk, for example, connectress, for example, congenital infection, you know that congenital CMV, congenital rubella, they can all have hearing loss as a sequelae. So in these patients, both OAE plus AABR are to be done, and they should be done within 24 to 48 hours. OAE alone will miss auditory nerve damage, it will miss many sensory neural hearing losses. It should be done within, combination of these two should be done within 24 to 48 hours, and then this combination should be repeated at discharge or follow-up. Now, if you keep this important, this is very, very important, and the fresh future question can be asked in both NEET SS and INISS. So, keeping that in mind, now the baby is being discharged, which test should be done prior to discharge? The answer would be clear, perform AABR in the patient. There is a chapter given in AIIMS protocol regarding hearing screening. You are supposed to go through that. Also go through the hearing screening of Nelson and just a reading given to the Cluharty part as well. But again, this, don't try to overdo the topic. Eventually, the examiner will just ask you what is to be used where and what is the screening protocol. That is the most important thing examiner will ask you. Moving to question number 12. Again, it is similar to NEET SS 2024 MCQ. So we are almost on to PYQs. So question says, a preterm neonate with poor feeding apneic episodes was evaluated by cranial ultrasound. He was having hemorrhage into the lateral ventricles of the brain. So there is intraventricular hemorrhage, which is common in preterm newborns. It is occupying 30% of the lumen, but there was no ventricular dilatation or parenchymal extension of the bleeds. What is the likely grade of IVH? I have discussed this topic in my detailed videos as well as in my updates, which are there in the notes, which are there in the detailed videos. They are there in rapid revision, and many of the students, not you people, but your seniors who appeared in this exam, they messaged me saying, sir, this question we could easily solve looking at the things that we had discussed. So what are the grades of IVH? It's a very simple question if you know the grades. The grades are of 4 varieties. Grade 1 is bleeding happening in the subependymal region or germinal matrix, but not truly reaching the interventricular space. Grade 2 will be extension into the ventricles, but the size is normal and it is less than 50% of the volume of the ventricle. Generally, it will be between 10 to 50% of the volume of the ventricle. Grade 3 will be extension into dilated ventricles. Now, dilatation will start, and grade 4 will be intraparenchymal extension of the IVH bleed. So when it extends into the parenchymal space, that will be grade 4. Or if you look at this, there is no ventricular dilatation, 30% of the lumen is being occupied. So this is grade 2 IVH. So if you know the grading, it's a very, very simple topic. Now, question number 13. 7-day-old neonate was brought with complaints of poor feeding. On examination, he had bilateral mild conjunctivitis, tachypnea, chest retractions, and leukocytosis. Gram stain from ocular secretion was negative. No history of purulent discharge on day 1 of life. What is the likely diagnosis? Now, this child is having sepsis-like presentation, probably pneumonia, and the child is also having bilateral mild conjunctivitis. Immediately it should come into your mind that which organism can cause both conjunctivitis and sepsis like pneumonia. You have chlamydia as the possibility. Sometimes staphylococcus, Staph aureus can also have a presentation like this. But staph will produce typical sepsis, and these patients will have leukopenia rather than leukocytosis. Leukocytosis means it is not a typical pathogen, and gram stain is negative means something which is gram negative or something which is atypical organism. So it is fitting into a diagnosis of chlamydial conjunctivitis. You need to start macrolide antibiotics in these patients. Remember, if examiner says there is superficial with deep infection together in a newborn, superficial infection in the form of conjunctivitis which is mild and occurrence of pneumonia-like presentation with leukocytosis, it goes in favor of chlamydia infection in the newborn. Why it is not gonococcal? Gonococcal conjunctivitis will present within the first 24 to 48 hours. There will be purulent discharge. The sepsis-like feature may or may not be there, but there is intense edema and chemosis of the eyelids which is present. That is not mentioned here. Purulent discharge is present, and when you do gram staining gonococcal conjunctivitis, you will find that gonococci, diplococci will be seen on gram staining, and you will have to then start third generation cephalosporin like ceftriaxone in the patient. And HSV and pneumococcal conjunctivitis anyways are not common. They are not a known causes of conjunctivitis. Rare atypical patients you will find, but they do not present like this. The answer to this question is straightforward: chlamydial conjunctivitis. Question number 14. All of the following are X-ray changes described in TTN. TTN is a topic we have discussed in details. You can go to through the detailed video. Look at the options one by one. Is there relative cardiomegaly? Yes, there is relative cardiomegaly. Is there sunburst appearance due to perihilar streaking? Yes. Sunburst appearance has been described because in TTN there is excess fluid which is accumulating in the lungs, and fluid in the interlobar fissure, this is considered radiological hallmark. In the fourth or fifth intercostal space on the right side there will be fluid present in the interlobar fissure, plus there will be diffuse haziness of the lung fields also which is produced. Low lung volume is not described in TTN. On the other hand, mild hyperinflation may sometimes be seen. Low lung volume is a feature of RDS, but it is not seen in TTN, and so the odd one out, and also the answer here is A. How does sunburst appearance look like? Look at this picture. You can see that there is hilar prominence, and small prominent white vessels will be projecting outwards due to fluid from the center, and there is some apparent cardiomegaly which is also being produced in the patient. So this is an X-ray which would go in favor of TTN. TTN is a topic we have discussed in detail, so you can go through the rapid revision part. It has been covered already. Question number 50. A preterm neonate of 28 weeks with RDS and a small PDA was given intratracheal surfactant using INSURE technique, and there was clinical improvement. However, 6 hours later, the neonate had further worsening with desaturation. What is the likely cause? Now you need to understand that SPB deficiency cannot be the cause, because SPB deficiency will show no response to surfactant. Polycythemia again cannot be the cause. Polycythemia, if it is present, it will predispose to thrombosis, or rarely it can lead to surfactant failure. Here the patient has initially responded, so it is not surfactant failure that we are talking about. Atelectasis again will not happen immediately, and atelectasis actually tends to improve when you give surfactant. It tends to open up the alveoli. Pulmonary hemorrhage is a known complication. In fact, within 12 to 24 hours of surfactant, if there is initial improvement followed by deterioration, one of the possibility you should consider is pulmonary hemorrhage. This patient has another risk factor for pulmonary hemorrhage in the form of small PDA. What happens in RDS patient is, when in a RDS patient with PDA, if you give surfactant therapy, surfactant replacement therapy is given, it leads to increased compliance of the lungs. And because of increased compliance, there is increased left to right shunt across the PDA. This leads to pulmonary congestion, and that pulmonary congestion in a preterm newborn with fragile vessels of the lung, it can lead to pulmonary hemorrhage. It can lead to pulmonary bleeds. This is the mechanism which is responsible for pulmonary hemorrhage happening in the patient. So the clues here are RDS patient, small PDA, initial improvement followed by worsening within 24 to 48 hours. One strong possibility will be pulmonary hemorrhage in the patient. Ironically, even in pulmonary hemorrhage, small doses of surfactant is useful because when bleeding happens, pulmonary bleeding itself can lead to secondary surfactant deficiency. So small doses of surfactant along with obviously NICU care, some degree of ventilation that will be needed in the patient, but it's a multimodal approach and no single one-liner kind of MCQ you need to remember. It's more of a practical thing that you will learn when you will be doing your DM in neonatology. Moving to question number 16. Again, question number 16 is a previous year question, NEET SS 2024. From what I was told was, sir, there were 2 to 3 lines, but this was the crux. So I'm not going into the details of the recall. This was the crux. Ballard score. What is Ballard score? There is a score known as expanded new Ballard score, which is a way to clinically examine a child and check for the gestational age by giving scoring system. There are 2 components, neuromuscular maturity, physical maturity, and we give a total score and see what is the total score corresponding to. So minimum Ballard scores look something like this, right? There are neuromuscular maturity, physical maturity, and different types of scores are given. What are we interested in? This particular thing which is present on the extreme right corner. Maturity rating. Let us have a look at it in a zoomed way. It says that the maximum possible score is 50, which corresponds to 44 weeks of gestational age, whereas the minimum possible score is 10, which corresponds to 20 weeks of gestation. So what is the answer? What is the minimum Ballard score? Minimum Ballard score is -10, which corresponds to 20 weeks of gestation. About Ballard score, what examiner can ask you? They can ask you, what is the purpose? They can give you the photograph and ask you what score it is. 3, they can ask you what are the 2 components, neuromuscular maturity, physical maturity. They can ask you number 4, how many components, how many items or testing do we do? 6 test items are there in neuromuscular, 6 items are there in physical maturity. And what is the total score? Minimum score -10 corresponds to 20 weeks, maximum score +50 corresponds to 44 weeks. This is all you need to know. This is all you need to remember. Moving further, question number 17. A neonatal chest X-ray is showing reticulogranular pattern. Likely differential diagnosis apart from RDS includes all except. We note that reticulogranular pattern can occur in RDS. It can also occur in older children with COVID-19 pneumonia, but both of them are not mentioned. So what other reticulogranular pattern diagnosis can be there in the patient? So there are a few possibilities that we need to consider. According to AIIMS protocol, reticulogranular pattern can be seen in patients with RDS. It can also be seen in patients with BPD, and it can be seen in patients with RDS mimickers. RDS mimickers on chest X-ray. What are the RDS mimickers on chest X-ray? AIIMS protocol says that we have hypoplastic left heart syndrome, which is a RDS mimicker on chest X-ray. You can have patients with TAPVR or TAPVC, total anomalous pulmonary venous connection, and patients with pulmonary venous atresia. All these 3 conditions will be having interstitial pulmonary edema. And because they have interstitial pulmonary edema, they can have presentation similar to RDS, and so they can all have a reticulogranular pattern. But remember, in RDS, X-ray is not diagnostic, but there are some findings that you can see. You can have reticulonodular shadows, ground glass opacities, you can have low lung volume, you can have air bronchogram sign where the lines, the air shadows in the tracheobronchial tree become visible, and advanced cases can show a whiteout lung as well. So if you see a pattern, RDS TTN this time exam, they did not ask directly, but they will be asking something related to the X-ray features or so. In fact, these questions which I have taken related to X-ray, they are similar to previous year questions asked in the exams, right? So answer to this question, which is the odd one out, reticulogranular pattern is not seen in TTN patient, and that is your answer. Question number 18. What shall be the next management step in a sick, unstable preterm neonate with NEC stage 3B who cannot undergo immediate laparotomy? You know that necrotizing enterocolitis, there is a modified Bell staging which is followed. 1A, 1B, 2A, 2B, 3A, 3B. 1A to 3A the treatment is conservative. So I'm just giving the heading summary of NEC. So treatment of NEC, if they ask you treatment from stage 1A to 3A, the treatment is same, conservative therapy. You give IV fluids, IV antibiotic, make the patient NPO, TPN, manage complication if any. Stage 3B, because 3B stage is characterized by perforation. So you have to do open surgery, you will have to go for laparotomy in the patient. And you will do resection of the perforated segment. But if there is stage 3B patient who is unfit for surgery, you cannot leave the patient like this. You cannot do conservative management also otherwise, because the fecal material is now contaminating the peritoneal space. Patient can develop septic shock and surgery cannot be done immediately. So what do? You take the middle path approach. Laparoscopy has no role. You will do peritoneal lavage in such patients. Lavage means cleansing through drains which are put through the flanks. Flank drains you will insert and you will put normal saline into the peritoneal cavity and then take out. That continuous process has to be done. Peritoneal lavage should be done using flank drains. And this should be continued along with conservative therapy till the patient is stable. Once the patient is stable, then you will take up the patient for surgery. Then open surgery will be needed. So answer to this question is B, peritoneal lavage and drainage. Question number 19. Which of the following best explains the mechanism of breast milk jaundice? Now there are traditionally two types of jaundice which you have read in exclusively breastfed child. One is called as breastfeeding jaundice, second is breast milk jaundice. However, the current textbooks and all the recent guidelines do not subscribe to these terminologies, and in fact breastfeeding jaundice is a misnomer. It is not, it just implicates breast milk as a culprit, when in fact breastfeeding jaundice is a innocuous, it is a innocent, and it is a benign entity. Breastfeeding jaundice occurs when you are not adequately feeding the child. So that is not truly a pathological jaundice. However, breast milk jaundice can sometimes occur as a cause of pathological jaundice. Breast milk jaundice is exaggeration of the bilirubin level. Unconjugated bilirubin level will rise, and this will rise somewhere between 2nd to 4th week of life. Why it will happen? Because either there are substances in breast milk which inhibit conjugation, like free fatty acids, pregnanediol, or there are substances which have glucuronidase action. Glucuronidase action means they convert conjugated bilirubin back into unconjugated. And so, earlier what we used to do was we would stop therapy in such patients, but therapy is no longer stopped. All these points I have already discussed in my rapid revision as well as detailed video. You are supposed to go through them. This I am summarizing. See, the things I have discussed already, I am just trying not to replicate them again, because I know you are watching and maybe listening to this video close to the exam, one last week before the exam as well, which you should. So I'm just, giving hints to you that you have read all these points before. Now, keeping that in mind, look at these options. They are asking the mechanism of breast milk jaundice. AIIMS protocol very clearly says that a few proposed theories for its occurrence are high free fatty acid concentration in breast milk causing bilirubin displacement from albumin, high beta-glucuronidase activity, and inhibition of UGT1A1 activity by breast milk contents. And interruption of breastfeeding is seldom required. We generally continue breastfeeding because as time increases, these children tend to improve. So the answer to this question is C, inhibition of conjugation by substances like free fatty acid and beta-glucuronidase in the breast milk. Question number 20. A day 4 neonate is having yellowish discoloration of skin and mucous membrane. So he's having neonatal jaundice. Total serum bilirubin is 15. He is on exclusive breastfeeds. What is the likely cause of neonatal jaundice? Now, let us put it very clear. It cannot be biliary atresia. Why? Biliary atresia is cholestasis. Cholestatic jaundice will occur if there is prolongation of jaundice beyond 2 weeks, and examiner will give you clues. Examiner will say dark colored urine, clay colored stool. None of them is mentioned. In a day 4 child with this bilirubin and no mention of dark colored urine, clay colored stool, you will not think of biliary atresia. It is not likely to be breast milk jaundice again, because breast milk jaundice there will be further clues, and in the first week of life, particularly first 4 or 5 days, we will not suspect breast milk jaundice. I told you the peak values, they tend to start somewhere around 10th day of life. It is 2nd or 3rd week that you will find breast milk jaundice to be present, and it is not a common thing. We are left with C and A. C is your pathological jaundice, A is your physiological jaundice. Whether it is physiological or pathological is guided by American Academy of Pediatric Normogram. This is the 2022 updated guideline program. I have discussed this in the updates on the PrepLadder app already. Look at this. Now this says that phototherapy thresholds with no hyperbilirubinemia neurotoxicity risk factors in a child. None of them are mentioned here. Now you will say, sir, they have not mentioned gestational age also. If gestational age is not mentioned, we assume it is a term baby. Even if we assume it is 37 weeks, these are the curves. So you have curve for 40 weeks and above, 39, 38, 37, 36 and 35. See, on day 4, this is day 4 child, right? Day 4 child, what is the cutoff? Even for 35 weeks, the cutoff is somewhere around 18.5. What is the value given? 15 milligram per deciliter. So 15 comes somewhere over here. So what will you do? Would you give phototherapy? No phototherapy. No indication for double volume exchange transfusion. So this is physiological jaundice. Probably reached its peak. Retrospectively, if no indication for therapy is being there and no clinical history, no yellow palms and stools, no cholestasis, nothing is mentioned, no encephalopathy mentioned, by diagnosis of exclusion, we say it is physiological jaundice. The answer to this question is A, physiological jaundice. Another way of reaching the answer, the older AIMS protocol also had some values. The older AIMS protocol used to say that what is the cutoff to minimum TSB to start phototherapy in the patient at 24 hours, it will be equal to or more than 10 milligram per deciliter. 48 hours of life, it is equal to more than 13. 72 hours equal to more than 15. 96 hours and beyond equal to more than 18 milligram per deciliter. So again, 96 hours and beyond, what should be the value? 18 and above. What is the value here? Day 4, 15 milligram per deciliter. So is the cutoff for treatment attained? No. If cutoff for phototherapy not attained, it is not pathological jaundice. No encephalopathy, no risk factor mentioned. It is a diagnosis of exclusion. Again, the answer is physiological jaundice. This question looks simple. It is not. Again, there is no definition. I repeat, there is no definition for physiological jaundice. It is common, but it is a diagnosis of exclusion. If the cutoff for therapy is not attained, no risk factor and no criteria for pathological jaundice are fulfilled, we say retrospectively it is likely physiological jaundice, which is the correct answer here. For more clarification, you can see the detailed videos. You will have no ambiguity regarding this question. Question number 21. It's a simple one-liner based question. It's a very similar question has been asked in INISS. It's a repeat question actually. INISS super specialty part of neonatology. It has been asked in 2021 or 2022. I'm not sure which year it was asked, but it was definitely there in the small collection that I have with me. So you're planning to start KMC in a low birth weight neonate. All of the following are contraindications for KMC, except this question is taken directly from the AIMS protocol. It was there in the older AIMS protocol also indirectly mentioned. So hemodynamic instability, yes, it is a contraindication. A child in shock, you will not give KMC. Recurrent seizures, obviously, you will not give KMC to the child. Post asphyxia, the child will require care, the child will require EEG monitoring, the child will require probably MRI and monitoring in ICU. KMC will not be started. Apnea is the answer. In fact, very clearly, AIMS protocol says apnea is not a contraindication for starting KMC. In fact, if there is a preterm or low birth weight child where apnea is happening, and starting KMC can prevent apnea, where the mother's movement acts as tactile stimulus for the newborn's breathing to start and to continue. Again, they are not saying that if apnea is there, would you give KMC? No. They are saying if apnea diagnosis has been made in a newborn, would you stop KMC? The answer is no. You will treat the cause of apnea. If it is a preterm child with apnea of prematurity, you will start caffeine citrate. But KMC will not be contraindicated in such a patient. Because I discussed about this question separately also in one of the forums, and many people were like, sir, but apnea patient, shouldn't we be doing tactile stimulation at all? Yes. Here it is not talking about an apneic episode. Understand? Somebody having apnea, you call it as apnea. Diagnosis is apnea. The apnea itself is not a contraindication for giving KMC. Obviously, during apneic attack, you will manage just like you manage any apnea, but it is not a contraindication to stop giving KMC in the child. Question number 22. Now, this is related to the HIV guidelines, the NACO guidelines. Pregnant woman is diagnosed with HIV infection at 34 weeks of gestation. Her viral load, this is important, 1200 copies per ml, and she was started on ART. She delivers a 2.5 kg term baby at 38 weeks. What is the most appropriate postnatal prophylaxis for the newborn? Let us come back to this question, try to understand what are the guidelines. NACO guidelines talk about HIV exposed infant. I will not go into the unnecessary details. The brief summary already discussed in the rapid revision part. What is HIV exposed infant? Any infant, any baby born to HIV positive mother or HIV positive pregnant female is called as HIV exposed. We don't know whether the baby is infected or not, but this is HIV exposed. HIV exposed babies, most of these babies, they are low risk for getting HIV. However, they are considered high risk if any one of the following is seen. What are these 4 things? First, if the mother is not HIV positive mother but not on ART. During pregnancy, she was not taking ART, so baby becomes high risk. Second, HIV diagnosed 4 to 6 weeks before delivery time. It has been diagnosed quite late in the pregnancy. So, it has been diagnosed 4 to 6 weeks before delivery, so it is a high-risk infant. Third, if guidelines say that any pregnant lady who is HIV positive, you should do a viral load testing at about 32 weeks or afterwards. If no viral load testing has been done, at or beyond 32 weeks of pregnancy, again you will call the baby born to such a mother as high risk. And fourth, if you find high viral load, what is high viral load? Equal to or more than 1000 copies per ml of HIV at or beyond 32 weeks in pregnancy, you will call the baby as high risk. Now, what is the treatment that you will give? First of all, in such a baby, the guidelines say whenever this baby is born, the feeding should always be exclusive breastfeeding. If you cannot give and parents are affording, then you can go for formula milk. We call it as exclusive replacement feeding. So EBF will be the mode of feeding, and you need to start the baby on antiretroviral prophylaxis from day 1. It will be given in all HIV exposed infants, not normal babies, HIV exposed infants, if the mother was HIV positive. So ARV prophylaxis, if it is a low risk infant, you will be starting the baby on oral nevirapine prophylaxis given once daily for 6 weeks. And if it is a high risk infant, you will be giving nevirapine as well as zidovudin, and the duration will be decided by the mode of feeding. If it is exclusively breastfed child, you will give for 12 weeks, and if it is exclusively replacement fed, you will give for 6 weeks. Regarding the testing and all, there is a separate protocol that is there in the detailed guidelines I have discussed in the videos as well as in rapid revision part. So you can go through that. So this is the summary of what you need to know. Now come back to the question and what is there. See, this is a lady at 34 weeks of gestation, viral load at or beyond 32 weeks, more than 1000 copies per ml. She is taking ART. So this is the baby born to this lady is a high risk infant. And in a high risk infant, you will give combination therapy and you will give it for 12 weeks because the baby is on exclusive breastfeeds. Now look at the options. A option is correct because you will give nevirapine and zidovudin for 12 weeks along with exclusive breast milk feeding. And that is your answer. Question number 23. A baby was born via normal vaginal delivery to a lady with chronic HCV infection. When should you perform testing for anti-HCV antibodies in the baby? First of all, you should know that there is no true way to prevent HCV transfer from mother to babies. You cannot really prevent. And doing cesarean versus normal vaginal delivery, again, the mode of delivery has not been found to be prevented. We need to do testing, but the testing needs to be done around 18 months of age. And based upon the test results, then you need to refer the patient and decide whether HCV RNA testing then will be done, and then you will decide whether you need to start anti-HCV drugs in the child or not. So what does the protocol say? AIIMS protocol has these very beautiful flowcharts given. So it says that neonate born to mother with HCV infection, and it clearly says mode of delivery has no effect on the perinatal infection risk. You start exclusive breastfeeding, it is not contraindicated. Follow-up testing should be done at or after 18 months of age for anti-HCV antibodies. If it is negative, there is no HCV, no action required. If it is positive, you will do HCV RN testing after age 3 years to confirm chronic HCV infection, and then you will refer the patient to expert, infectious disease expert, and take the opinion of pediatric hepatologist and decide what next needs to be done. The answer to this question is D, at 18 months of age. Question number 24. Now we have some congenital infections. Many of them are easy as well. Which of the following congenital infection carries maximum risk of type 1 diabetes mellitus in later life as a sequela? Why have I added this question? This is INISS 2022 MCQ. So, maximum risk of type 1 diabetes mellitus, it is congenital rubella. Rubella is a unique virus. In utero infection can cause sequelae. One of the delayed complication is it sensitizes the body for autoimmune reaction against beta cells of islet of Langerhans. And in the first decade of life, this child has higher risk of developing autoimmune, that is type 1 diabetes mellitus. Question number 25. Identify the incorrect statement regarding congenital CMV. Congenital CMV is one of the common congenital infections. Vast majority are asymptomatic, but they do carry a risk of hearing loss. Let us look at the options one by one. Option number A, 90% are asymptomatic, but 5 to 15% develop hearing loss. It is a true statement. Mostly it is asymptomatic, but hearing loss can occur even in asymptomatic individual. Although the hearing loss prevalence is more common in symptomatic CMV, but even asymptomatic patients can develop hearing loss. Second, saliva or urine PCR are more sensitive than blood PCR is again a true statement. For doing PCR, saliva and urine are always preferred, and the testing should be done within the first 3 weeks of age. After 4 weeks are done, after the newborn period is over, the chances of getting a positive PCR are negligible. Remember, saliva is easy to collect. It is preferred for general screening. But if you have to do diagnostic, highest yield is found in urine, and so urine culture can also be done, which is a gold standard investigation. Asymptomatic infections do not need ganciclovir is a true statement. Ganciclovir is drug of choice, but it is needed only in symptomatic CMV. Asymptomatic patient risks outweigh the benefit because it's a very potent bone marrow suppressive agent, and so we use only in symptomatic. So we use only in asymptomatic patient, risk outweigh the benefit, and that is why we use ganciclovir. It's a potent bone marrow suppressive agent only when the patient is having symptomatic CMV. So what are we left with? Option number D. Follow-up needed for 6 weeks in asymptomatic infants to detect hearing loss. False. According to IMSS protocol, there is a beautiful protocol, there is a beautiful flowchart they have made, and even in Cloherty and Nelson they mention follow-up is needed for not 6 weeks, it is needed for 2 years. Up to 2 years you need to follow up these patients because chronic ongoing damage can manifest up to 2 years. So OAE, AABR should be done at each visit up to 2 years of age in these patients. They are asking incorrect statements, so answer to this question is D. Question number 26. In a suspected case of congenital hypothyroidism, what is the ideal time of blood sample collection? Earlier, we used to collect at umbilical cord blood at the time of birth, but it is not a favored way because there is a physiological surge of TSH which happens at the time of birth, and the ideal time is at 72 hours of delivery. And how do you collect it? You do a heel pad prick. And for general screening purpose, although India doesn't have a proper, nationwide screening program, but heel pad prick, you generally check for serum TSH. It is a capillary blood which we are using, not a venous blood that we are using. But interpretation related questions can be asked to you. So what additional you need to know, especially from INISS point of view. Now, you have taken out heel prick and you have checked the TSH value. The values will be coming in milliunits per liter. What is the interpretation? If the heel prick TSH value is less than, equal to or less than 20 milliunits per liter, you will say it is normal sample and no further testing is needed. If the heel prick value is 20 to 40 milliunits per liter, it should be above 20, right? 20.1 you can say till 40 milliunits per liter. It is called as borderline value. And in such patients, you will have to repeat the entire TFT. When I say TFT, you have to do TSH, T3, T4, all three of them at 7 to 10 days of life. This we have done at 72 hours. This is 72 hours of life. Okay. Third possibility, if it is between 40 to 80 milliunits per liter, 40.1 till 80, then it is considered to be a positive test. And in these patients, you will not start therapy immediately. You will send venous sample immediately or at 72 hours for complete TFT and then decide. Then you will decide therapy. What therapy? Levothyroxine, whether it is to be started or not. And any value more than 80 milliunits per liter, here it is a positive test. But you will start levothyroxine immediately. Start levothyroxine immediately. And plus you will send venous sample for TFT. Right? So you can get case scenarios asked on this, similar to a table given in AIIMS protocol. Many review articles have it. I have given and written in a way that you can remember and apply in your MCQs also easily. Write it somewhere, you might get a question on this in your exam. In fact, similar questions are very frequently asked in INISS exam. Question number 27. 4.5 kg term neonate born to diabetic mother was diagnosed to have unilateral renal vein thrombosis without any IVC extension on day 2 of life. What is the next step in management? We know that infants of diabetic mother are predisposed to polycythemia and increased risk of renal vein thrombosis. If renal vein thrombosis happens, how are we going to approach? Again, AIIMS protocol says treatment of neonatal RVT, renal vein thrombosis. If it is unilateral RVT, two possibilities. No IVC extension, it is just a localized one, small thrombus. And second possibility, IVC extension, it has extended to the IVC, inferior vena cava. If there is no IVC extension, give supportive therapy and do serial radiological monitoring. Supportive therapy, treat the underlying cause, serial radiological monitoring should be done. On the other hand, if there is IVC extension, you will have to start the patient on either unfractionated heparin or low molecular weight heparin. However, if the patient is having bilateral RVT, obviously these patients will have renal impairment also. So renal impairment also. Renal failure will be happening in these patients. So underlying renal failure, whatever you have to manage, you will manage. In these patients, you have to do thrombolysis. Thrombolysis followed by UFH, unfractionated heparin. Alternative, another possibility you can consider is you can directly start with the UFH or LMWH if any contraindication to thrombolysis is present. So this is the summary. You can write it somewhere, revise for your notes. Now here there is no IVC extension and unilateral RVT is there. So next step in management will be observation. If you have not read the topic, you would think, oh, how can we observe? There is already renal vein thrombosis happening. Sometimes observation is the best way. It is the best thing you can do. You don't need to intervene at all the times. Question number 28. It's a tough one. It is looking like a tough one. It is a tough one, but again, I'll summarize what you need to know. So, extremely low birth weight newborn is receiving TPN, broad spectrum antibiotics, IV fluids, suddenly deteriorates. There is no occult blood in stool, so no NEC, and increased ventilatory requirement. He was already on fluconazole prophylaxis, and the blood picture reveals hyperglycemia, thrombocytopenia, raised CRP. Raised CRP means there is likely infection or inflammation somewhere. Hyperglycemia, thrombocytopenia are subtle clues. They are not diagnostic, but subtle clues. In a ELBW child, it could be fungal sepsis. The question is, the patient is already receiving fluconazole prophylaxis, blood culture is not there. What will you do in the meanwhile? Let us see from a different perspective. What is the information that we have? This is the question, right? I have removed the options. We'll come back to the question again. This is the question which is given to you. Now, what are the possibilities given to you? This examiner is saying ELBW neonate on antibiotic, deterioration with increased need for ventilation, hyperglycemia, reduced platelet, increased CRP. First possibility in such a patient will be fungal sepsis. But patient is already on fluconazole. Just being on fluconazole does not mean patient cannot have fungal sepsis. Candida albicans, yes, it responds to fluconazole, but there are other varieties of Candida which can still happen, which are common and they can still happen even if fluconazole prophylaxis is being given. AIMS protocol says most Candida species are susceptible to both fluconazole and amphotericin B except glabrata and krusei, which are intrinsically resistant to fluconazole, and Lusitania, which is resistant to amphotericin B. And that is why amphotericin B deoxycholate is the first line therapy in such patients. So what you will do in the patient? This is a patient with likely fungal sepsis. Patient is receiving TPN, so there will be central venous catheter. CVC tip culture, you will remove it, put a fresh CVC, send hemogram and RFT to see, there should not be any contraindication, no potassium abnormality, no renal dysfunction, and you will start amphotericin B as the first line therapy in the patient. Look at the other option. Echinocandins plus meropenem, empirically no, echinocandins are second or third line antifungals. And meropenem for what? We sometimes use meropenem just like that, but there has to be a reason for using meropenem. Don't use meropenem just like, patient deteriorator, we put on meropenem. This is again not the right way to treat a patient. Whenever you are using colistin, wherever you are using meropenem, you should always be questioning yourself, what is the rationale I have to use these antibiotics? Don't blindly fire into airs. So adding linezolid, waiting for a culture report. Linezolid will be for VRSA patient. What are we thinking of VRSA here? Anything to suggest that except for worsening? No, none. Why azithromycin? No rationale again. In a newborn, very limited role of azithromycin in such patient. So best answer, even if you apply some common sense, is B. So what do we need to know about the fungal sepsis part? Some additional points taken from AIMS protocol. What is the most common cause of invasive fungal sepsis in newborn? It is Candida albicans, followed by Candida parasilosis. Other common pathogens, they do include glabrata as well as krusei as well. Maximum risk of fungal sepsis is seen, according to AIMS protocol, if the newborn is having extreme prematurity, NEC, gastroschisis and bowel perforation. Presence of IV fluids and broad spectrum antibiotic cover are additional points as well. Blood culture is the gold standard and 90% are positive within 72 hours. Initial drug of choice, I already told you, amphotericin B. Fluconazole is used if no prophylaxis has been given for. Earlier it used to be IV fluconazole, now we go for amphotericin B. Echinocandins like mica fungin are useful in refractory cases if it is not responding to fluconazole or amphotericin B or if they are contraindicated. Now, bloodstream infection is cleared in 3 days, but therapy is needed for 2 weeks after documented clearance from the bloodstream. It is not 2 weeks absolute. After it has been cleared and the repeat blood culture is negative, after that you will give for 2 weeks. And if it is meningitis, you will give for 3 weeks. So, long-term therapy, sometimes for 4 to 5 weeks also, you may end up giving antifungal therapy in such patients. What about one-liner? This is an old one-liner on INI set. I have already discussed in my regular video also. All ELBW neonates in NICU should receive fluconazole prophylaxis for 6 weeks. Question number 29. Which of the following is not a strategy to reduce incidence of BPD, bronchopulmonary dysplasia? 4 options are given. Let us first do a quick review. What does AIMS protocol say? Strategies to reduce BPD, evidence-based guidelines, Cochrane-based guidelines and AIMS protocol-based guidelines. First of all, early nasal CPAP, restricted use of oxygen have been shown to reduce the BPD risk. Obviously, in a RDS patient, because they will reduce the need for ventilation and oxygen-derived free radical injury will also be less. Early rescue surfactant reduces BPD risk, but prophylactic surfactant and late surfactant use do not reduce BPD risk. Early TPN followed by early enteral feed transition also reduce BPD risk. Volume targeted ventilation reduce BPD risk. AIMS protocol further says that using patient triggered ventilation like SIMB, it is generally used and it should be used, but per se itself it does not reduce BPD risk. Then caffeine citrate, steroid use beyond 8 days of life, beyond first week of life in ELBW neonates reduces the BPD risk. What about steroid use in the first 7 days in a ELBW newborn? Benefits do not outweigh the risk. Risks are more. Cerebral palsy, hyperglycemia, infection risk, all these problems risk are there, and that is why they should not be used, and so as a BPD reduction strategy, they should not be employed. This is what the protocol says. Then fluid restriction, vitamin A, diuretic use, steroids in first 7 days, doubtful role. Doubtful role means some benefit is there, but again studies are either conflicted or the risk outweigh the benefit. That is why we are not using them. They should not be the answer unless you are left with no option in your exam. And early NIPPV, no role in reducing BPD risk. Antenatal steroids. Now, this is an interesting thing. AIMS protocol says antenatal steroid reduce the risk of RDS. They do not reduce the risk of BPD. But if you look at the flowchart given in AIMS protocol, they mention antenatal steroids. Antenatal steroids are given. Antenatal steroids given to pregnant lady with preterm labor because they reduce the risk of RDS, right? So indirectly, yes, but because antenatal steroids also help in, the baby getting saved, young, very premature babies getting saved. So BPD risk per se does not get reduced in them. So you should not be marking in the exam, and that is why I have kept it separately with a different color. In the text, they clearly mention antenatal steroids do not have a role in reducing BPD risk. Permissive hypoxemia. Permissive hypoxemia means tolerating SpO2 value of 88 to 89%. You know the target is 91 to 95, right? Tolerating somewhere around 88-89%, no role. Permissive hypercapnia, PaCO2 on the higher side, if you tolerate it, no role. Prophylactic PDA closure, again, no role in reducing BPD risk. And experimental therapies I have not commented upon because the evidence for that is lacking. With this in mind, let us go back to the question now. Which of the following is not a strategy to reduce incidence of BPD? Option number D, early rescue surfactant therapy using LISA and MIST. Yes, it is a strategy which can be used. Prophylactic caffeine in less than 28 weeks, even if no apnea. Yes, it can be used. Early initiation of high frequency ventilation in neonatal respiratory distress. Again, it is plus minus, and studies have shown that it has been used in severe RDS, particularly associated with air leak, where you start high frequency ventilation early. It has been shown to reduce the barotrauma and the various types of volume trauma which can trigger BPD in the patient. So this can be used in ventilated where mechanical ventilation is indicated. What about option number A? Prophylactic steroids in the first 48 hours of life in ELBW neonates. What did I tell you? Steroids in the first 48 hours of life or in the first 7 days of life. It is not a BPD prevention strategy. Risk outweigh the benefit, and AIMS protocol says they should not be used. And so the best answer among the options given is A. B is a close one, but if you read the text and if you read the text given in other textbooks, you will find that B also can be a strategy to reduce incidence of BPD in severe RDS where ventilation is required. The threshold should be lower for using high frequency ventilation. Question number 30. Manning's BPP scoring criteria includes all except. Remember that fetal heart rate is not a criteria. Biophysical profile, 5 components are there. You can remember the mnemonic Batman. So breathing movement, amniotic fluid assessment, tone of the child, movement of the fetus, and non-stress test. So fetal heart rate is not included, and that is your correct answer. Before I finish, just one suggestion. All the topics we have discussed, don't miss them from AIMS protocol. Neonatal resuscitation, neonatal jaundice, either polycythemia or hypoglycemia occasionally, neonatal sepsis, hearing assessment, first chapter of Cloherty, and therapeutic strategies for RDS, TTN, BPD, their X-ray features, diagnostic part. This will cover almost 40-50% of what you need from entrance point of view, for NEET SS point of view. And INISS related points and topics I have already told you. So I hope you all benefit from it. Thank you so much.